Hello everyone, a very good day. I'm Dr. Nancy Elizabeth, Assistant Professor from Department of Ophthalmology at Sree Balaji Medical College and Hospitals. My lecture today is about diabetic retinopathy. It comes under the competency OP 9.2. The specific learning objectives of the topic is that at the end of this session, the student should be able to define diabetic retinopathy, explain the pathophysiology, list the risk factors, classify, identify the fundus feature of NPTR and PDR, outline the screening protocol and the principles of management. So going in detail about diabetic retinopathy. So what is diabetic retinopathy? It refers to the retinal change seen in patients with diabetes mellitus. In Western countries, it is one of the leading cause of blindness. Etiopathogenesis. So the duration of diabetes can imply the diabetic retinopathy status. So if the diabetes is present for 10 years, then there is a 50% chance of developing diabetic retinopathy. And if it's 20 years, then it is 70% chance of diabetic retinopathy. And if it's 30 years duration, then the chance of developing diabetic retinopathy is 90%. And the female to male ratio is 4:3. Poor metabolic control. Hereditary also plays a role, which is transmitted by recessive trait without sex linkage. And this type of hereditary pattern is more common with proliferative diabetic retinopathy. And pregnancy can accelerate retinopathy changes, hypertension, and other risk factors like smoking, obesity, and hyperlipidemia. Pathogenesis of diabetic retinopathy. So the changes mainly occurs in the veins. So the vascular change in diabetes mellitus are the following. So initially there is thickening of the capillary basement membrane. This leads to capillary endothelial cell damage, and also there are changes in the red blood cells. And in platelets there is increased stickiness of platelets and followed by loss of pericytes. So these changes in turn can cause microvascular occlusion leading to retinal ischemia. The retinal ischemia further progresses into capillary leakage. So the signs that we see in the fundus would be microaneurysm, hemorrhage, retinal edema, hard exudates, AV shunts, that is also called as intraretinal microvascular abnormalities, and neovascularization. Classification of diabetic retinopathy. So though there are many different classifications done previously, the current classification is as follows. It is divided into 4. The first one is non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, which is PDR, diabetic maculopathy, and advanced diabetic eye disease. In which the non-proliferative diabetic retinopathy, NPDR, is further classified into 4 subtypes: mild NPDR, moderate NPDR, severe NPDR, and very severe NPDR. So what are the ophthalmoscopic features of non-proliferative diabetic retinopathy? So the first one is the earliest detectable sign is microaneurysm, which will be seen in the macular area, which is nothing but saccular outpouchings occurring in the capillaries. Then we have retinal hemorrhages. There are 2 types of hemorrhages, one that occurs in the deeper retinal layers, which is called dot blot, and superficial layers of the retina, which is called flame-shaped hemorrhages. The third one is hard exudates. These are nothing but yellowish, white, waxy looking patches arranged in circinate pattern in the macula. Retinal edema, this is characterized by retinal thickening. cotton wool spots, which are fluffy white retinal spots occurring due to ischemia of the nerve fiber layer of the retina. Then venous abnormalities such as bleeding, looping and dilatation can be seen. Intraretinal microvascular abnormalities or AV shunts that can be seen in fundoscopic examination as well as in FFA. Classification of non-proliferative diabetic retinopathy on the basis of severity. So mild NPDR, here at least one microaneurysm should be present in the retina. Moderate NPDR, here microaneurysm or intraretinal hemorrhages may be present along with hard exudates may or may not be present, and mild intraretinal microvascular abnormalities may be noted. Severe NPDR, this follows 4-2-1 rule. So any of one of the following is present, then we categorize it as severe NPDR. So there can be any one of the following: 4 quadrants of severe microaneurysm or intraretinal hemorrhage, 2 quadrants of venous bleeding, and 1 quadrant of intraretinal microvascular abnormality changes. In very severe NPDR, the same rule applies, but here any 2 of the following should be present. So 4 quadrants of severe microaneurysm or intraretinal hemorrhage, 2 quadrants of venous bleeding, or 1 quadrant of IRMA changes can be present. So here is a picture showing the mild and moderate NPDR. So in the first picture, the mild NPDR, you can see the microaneurysm. This is a small dot-like hemorrhage seen. In moderate NPDR, there is microaneurysm. Along with that, there is a dot plot hemorrhage which is slightly larger than a microaneurysm. And then you can see some hard exudates which are yellowish, waxy looking lesions. So in severe NPDR, along with dot plot hemorrhage and microaneurysm, we are seeing some venous bleeding is present. The changes in the veins can be seen. In very severe NPDR, any of the 2 can be present or all of it can be present. We categorize it as very severe NPDR. Proliferative diabetic retinopathy. So this develops in more than 50% of the cases after 25 years of the onset of the disease and is more common in juvenile onset diabetes, that is type 1. So what is a hallmark of PDR? There can be appearance of neovascularizations or new vessels. So these new vessels can be seen on the optic disc or elsewhere in the retina. Hence it is also called as neovascularization of the disc or neovascularization elsewhere. So where do they appear? They appear along the major temporal retinal vessels. And these new vessels, they proliferate from the retina into the vitreous cavity and appear as vascular fronts. As days goes by, later on, they condense and form connective tissue at the new vessels, causing epiretinal membrane. This further in turn causes vitreous detachment, and vitreous hemorrhage can occur if the blood vessels break. The PDR is classified as PDR without high-risk characteristics, that is early PDR, and PDR with high-risk characteristics, that is advanced PDR. So how do I say the high-risk characteristics? So based on the following 3 criteria, we call the high-risk characteristics. So there is neovascularization of the disc, NVD, 1/4 to 1/3 of the disc area. Vitreous hemorrhage or preretinal hemorrhage can be present or absent. When there is NVD less than 1/4 disc area with vitreous hemorrhage or preretinal hemorrhage, or it can be neovascularization elsewhere, NVE more than half disc area with vitreous hemorrhage or preretinal hemorrhage. This is a picture of PDR, proliferative diabetic retinopathy. You can see in the optic disc has numerous small blood vessels which are called neovascularization of the disc. Also we can see similar new vessel fronts that is seen elsewhere in the retina, so which is called as neovascularization elsewhere, NVE. So moving on to diabetic maculopathy, which is very important. because the major cause for defective vision in a diabetic retinopathy is due to diabetic maculopathy. So this diabetic maculopathy can be associated with non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. So why does this edema occurs? Maculopathy occurs is due to increased permeability of the retinal capillaries. So again we call diabetic maculopathy as clinically significant macular edema. So if one of the following criteria is present, we call it as CSME. So how do we identify this? By using slit lamp examination with 90 diopter lens. So the following three, any of one can be present. There can be thickening of the retina at or within 500 microns of the center of fovea, hard exudate at or within 500 microns of center of fovea associated with retinal thickening which is of one disc diameter or larger, a part of which is within one disc diameter of the foveal center. So diabetic maculopathy can be classified based on fundus fluorescent angiogram into four types. So first one is focal exudative maculopathy, where only focal points of microaneurysm, hemorrhages or hard exudates can be found in the retina. Diffuse exudative maculopathy, where hard exudates, microaneurysm and hemorrhages can be seen diffusely in the macular area. Ischemic maculopathy, here more of ischemic areas are seen, which are also called as foveal avascular zone or FAZ. Then mixed maculopathy, which combines both exudative and ischemic maculopathy. Advanced diabetic eye disease is the last stage, which is an end result of an uncontrolled proliferative diabetic retinopathy. And when do I say advanced diabetic eye disease? When the patient has persistent vitreous hemorrhage, tractional retinal detachment or neovascular glaucoma. So management. So first we have to investigate the patient. The most common blood investigation that we ask for is blood sugars, which includes the fasting, postprandial and HbA1c. Then we can do urine routine. A complete blood count is also taken to rule out anemia and other electrolyte imbalance. Then renal function test is done. Cholesterol levels should also be done. And then we can plan for fundus fluorescent angiography. So management, the first part is preventive visual loss and timely intervention by screening. So how do we screen a diabetic patient? So screening is done every year when there is no diabetic retinopathy or mild diabetic retinopathy in a diabetic patient. And 6-month screening is done for moderate NPDR, 3-monthly screening for severe NPDR, and 2-monthly screening for PDR with no high risk characteristics. So medical treatment, one by control of systemic risk factors like blood sugar, lipids, anemia and hyperproteinemia, and few pharmacological drugs can be given, modulatory drugs can be given like anti-vascular endothelial growth factors and antioxidants, and intravitreal steroids can be given, which is given as an intravitreal implant or intravitreal triamcinolone, which is a steroid. Role of laser photocoagulation. So this is the mainstay in the treatment of diabetic retinopathy and maculopathy. The laser that is used here is argon or diode laser. So first is macular photocoagulation. So this is done for CSME, that is clinically significant macular edema, and PDR with the CSME. So here we do before doing a pan-retinal photocoagulation, because once we do pan-retinal photocoagulation, a patient with CSME can progress with further macular edema. So it is done in two ways. First is a focal treatment. Here all the focal microaneurysms occurring in the spots are photocoagulated using a laser, which is 500 to 3000 microns from the center of the fovea. The spot size would be 100 to 200 microns with a duration of 0.1 second for each burn. Next is grid treatment. This is used for diffuse macular edema. The second one is pan-retinal photocoagulation. So here it destroys the ischemic retina, which is responsible for producing any vasoformative factors. So indications for PRP is PDR with high risk characteristics, neovascularization of the iris, severe PDR with the poor compliance for follow-up, or we plan for cataract surgery or any eye capsulotomy procedure, patients with renal failure, one-eyed patients and pregnant patients. So these are the indications for pan-retinal photocoagulation. So how do we do it? So we use scatter laser and we do 1200 to 1600 spots of burns, and each spot would be 500 microns in size and the duration of the burn would be 0.1 second. So where the laser burns are given, it is given at 2-3 disc areas from the center of the macula up to the equator and periphery. And the temporal quadrant is done first. So this is a picture showing focal laser. The black spots or the laser burns. A focal laser is done in one particular area where the microaneurysm or IRMA is seen. Grid laser covers the macula area. You can see it is a reversed C pattern. But the center of the fovea is not touched. It is done away from the fovea. And then you can see pan-retinal photocoagulation, the third picture, where it is done in the peripheral part of the retina up to the equator. So surgical treatment is the final treatment, and this is done for only advanced cases, especially the advanced proliferative diabetic retinopathy. So what are the final method of treatment is surgical treatment. This is done only in cases of advanced proliferative diabetic retinopathy. So what are the modalities of surgeries that can be done? So first is vitrectomy, a pars plana vitrectomy. This is done for any persistent recurrent vitreous hemorrhage. If there is any retinal detachment, then retinal detachment repair and procedures are done. So, to summarize, that diabetic retinopathy is one of the leading cause of blindness. The major cause of defective vision in diabetic retinopathy is due to diabetic maculopathy. Hence, early detection by screening of retina in diabetic patients is mandatory, and control of blood sugars along with timely intervention with laser can prevent the progression of the disease and vision loss. Thank you.